what is this population? This means whether it's the Montagnard community, whether it's the Karenni community, the Bhutanese community. The problem is trying to describe these communities, or this particular community, if it's a Montagnard community, in a nutshell, what are they? So to use the Montagnard community as an example, but could also apply to several other communities that we work with. The Montagnard community, number one, the name. The name is a colonial name, so it's problematic, right? Montagnard is French. The second thing is they, according to Western standards, research, blah, 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 all that stuff, they can be indigenous. They are indigenous Central Highlands. They're transnational to the extent that they have existed in what are the nation states of Vietnam and Cambodia, right? They can be described as tribal because there are multiple tribes with, in the case of the Montagnard communities represented here in our area, they represent 5 distinct languages, not dialects, right? But languages, 5 distinct languages, right? And then within those languages, there are dialects. For example, Dirai, I think, has 2 or 3 dialects that we hear. Cheoreo, Pleiku, and one more. But you get the idea. By the time I am challenged to put all of this about what is the community that we wish to study, by the time I try to write this into a 200-word grant box, it's almost impossible to do. So you see how we have come back and we're using this term, low-income Asian American communities of refugee origin. This is also supported by other data. For example, in a research that was done, it was shown when you look at Asian American population in the United States divided by quintiles, 20%, 20%, 20%, 20% in income. On the very top, you have the very well-to-do, very rich Asian Americans. That would be exemplified by, if you saw that movie, Crazy Rich Asians, which I did not see, they're talking about that. That is a super high level of income, right? Then you look at the very lowest income quintile. And who is in that? It's disproportionately represented by Asian communities of refugee origin. It does not mean that all Southeast Asians are poor, but they are disproportionately represented in the lowest quintile. How low was that? This is a little bit old data, but how low is that? They're talking about $17,000. If you want to know what the highest quintile was, it's something like 300,000. I think that spread represents within Asian American category, this is US category, right? AAPI, that represents the greatest gap, the greatest disparity between rich and poor, period. So when we apply to grants that might be for Asian Americans, we got to compete against rich people. No, that's not true. I am Chinese American. Chinese American people have been well established in this country. On paper, I am very well-to-do. I'm very rich. And as I tell everybody, no, I'm not. But you get the idea. You get the idea when it comes to trying to represent. And one of the difficulties we've had is trying to narrow that gap of understanding. That if you just talk about AAPI, right? If you just talk about AAPI, you're missing a lot because there's this gigantic difference in histories, background, culture, and so on. And as we heard this morning, culture and history count a lot, right? And we know about all the other language about transgenerational issues, that things go from one generation to the next generation. Poverty, obviously, because we're in America, right? And one of the few ways, I'll say before handing this over to Dr. Morrison, who will come in here just briefly, is that one way of getting out of the poverty trap in America, one of the few ways left, is through education, period. I mean, if there are other ways out there, let us know. But I think we know that for whatever you think about the American dream story, education is one of the few ways out of poverty. And we do see this within the Montagnard community. We see the young people represented here who are becoming professionals, who are the pride of their community because they're moving on up, so to speak. And they're not forgetting those who they leave behind. So with that, that is an introduction to the kind of work we do, kind of the struggles that we... And so now I'm going to leave it over to Dr. Morrison.
Thank you all. I hope you were able to have some conversation and chew and chat. Did you all get your lunches? All right, mine's here, so as soon as I'm done, I'm going to chow away. But I want to take 1 second and introduce you to Pastor Htay. Pastor Htay is one of our elders that made it out. Busy person, so I just want to recognize. Thank you for being here. We've collaborated. He's been in my classroom since 2002. So I have been privileged. The other thing that Pastor Htay, his church is a site for health outreach. And if you don't believe me, I have never been anywhere where we say vaccines, flu vaccines, 10 o'clock, and by 9 o'clock, everyone's lining up. So the outreach people are usually late. So I just want you to know. So I want to thank you, and thank you for being on our campus once again. Yes. Okay, so we are going to do a drive-by, 8 minutes, because we're back. So everybody, if you can follow with 8 minutes, Dr. Sudha and I are going to talk about elders in focus. So we might have to dim this a little bit for you to see. I apologize. Welcome again, and we thank you, and we're grateful for this opportunity. We've titled this Elders in Focus, and this is a call from the community to look at the needs of older adults in these communities. And Dr. Sudha is a gerontologist, and I'm her sidekick, and here we go.
Generally speaking, the needs of older refugees are sidelined because they are bundled with either the community needs or the family needs. And as this quote from the author LIAACRO says, gendered, racialized, and ageist assumptions shape notions of who is deserving. Neoliberal frameworks place a monetary value on life in humanitarian settings. And number 3, older refugees are not considered value for money in crisis responses. Older refugees form about 4% of a refugee stream, but in addition, refugees age up, living decades in refugee camps and also in their destination countries. And somebody said, how long are you considered a refugee? And so, as you're aging up, that's a question. So our presentation focused on 2 refugee communities of Asian origin, the Montagnards, originally from Vietnam, who have been in the US since the mid-1980s, and the Nepali-speaking Bhutanese, who are more recent arrivals in the last decade. So focusing attention on the situation and needs of refugee older adults is not routine. The Center for New North Carolinians, which is a service provision and coordination entity at UNC Greensboro for diverse newcomer communities in the state, describe their struggle to meet the needs of community older adults.
So the ask from the community, in particular Liana, who sat down as executive director and called a group of us known as the research fellows at the Center for New North Carolinians, as well as other advocates, asked that we assess, as well as members from the Bhutanese community, that we assess needs, look at gaps in existing available refugee services, but then look at the barriers facing accessing existing services. The big thing was to call attention to policymakers, funders, community members, the public in general, about the needs and the strengths and the resilience of the older adults in the community, which we heeded. Why? Needs are less addressed and known. The international migration streams are growing older. So normally younger people arrive, but now it's growing older. And we're talking about those age 51 to 64 years, but 65 and above form 14% of the population, including for Bhutanese. So when we look, 25 to 30% of Montagnards are older than age 50 and above. So this is not a future problem, it's here. Age is a social construct, and so we can be measured chronologically or functionally or through social roles. And given some of the trauma and the trauma history you've heard, it can people prematurely age. So these are important things. So in our needs assessment project, we include anyone who's self-identified as an older person. The two communities we're featuring here, though we've looked at other communities, the Montagnards you've heard a lot about, the more recent Nepali-speaking Bhutanese community was also part of this. And so we present this information. We describe the historical context. You've heard a lot about this so far, methods of gathering information and findings. And then we used our strategy working through community members that included oral histories, then designed in partnership with students and members of the community, provider surveys, and did document reviews. A lot of this also, some of this occurred during COVID, so it was not an easy thing to accomplish.
So the key question areas using open-ended questions was, what is the general background of the kind of organization or community you represent? What is your view or experience of the service provided? What services do you provide? And what is your perception of the primary needs and challenges of the community? The oral history and storytelling with elders, which Melina had described earlier, encourages older person to tell the stories of their lives in Vietnam and recount experiences recently with the US health and social systems. So these included big picture grand tour questions down to the historical context, down to local needs, and then follow-up questions based on their needs.
So 26 provider surveys were completed. We had 28, but these were those two could not be used. We also looked at interview field notes from interviews done with Montagnards as well as Nepali speaking older adults, and then community leaders. So in terms of looking at what's missing, in terms of structures, in terms of access, we think about many organizations rarely offer outreach to diverse populations. And these are underserved. And we're being clear. So when we talk to them, the area healthcare providers did not necessarily have targeted to diverse underserved. The society safety net has gaps through which many older refugees fall. Older refugees face barriers in accessing existing services, especially with language. Senior centers, however, offer supportive services such as meetings, informational sessions, some transportation, and meals. So that's a good thing. And then community organizations and natural helpers are the ones that try to fill all these gaps. So we'll focus now on some of the results and some recommendations from our needs assessment.
And what Dr. M had put up as to what was discussed 10, 15, 20 years ago is still the priority needs. Number one, lack of public transportation and the expense and difficulty of buying and maintaining a car. Without transportation, you cannot access work, healthcare, services. Second, employment and income closely connected to lack of English proficiency and the increasing difficulty in finding a job. Lack of employment means lack of income, which contributes to food and housing insecurity. Even when people find jobs, the income is low and insufficient for needs. Number three, English classes. Older refugees find it more difficult than younger ones to learn English despite attending ESOL classes diligently. Number four, healthcare. Barriers include language, lack of health insurance, The recent Medicaid expansion has yet to percolate to all segments. There is also a lack of comfort with healthcare interpreters and translators. For example, a Montagnard woman stated she would rather use her children for interpretation than the ones offered by the healthcare provider, but that is not considered a recommended practice in the world of interpreting and translating. And finally, culture and family. There is a generation gap between the older refugees and the younger generation who have learned English and are often losing their heritage languages. This contributes to loneliness and isolation on both sides. Family ties are disrupted as some people had family in the homeland who could not migrate with them. So there is the sadness associated with being away. Okay, so yeah, we're not reading out these, it's just a summary.
We just want to show you the summary of some of the things that we found.
And the same issues were identified by service providers as community members, but the interpretation was a little different. For example, community older adults experienced loneliness and isolation and asked for group activities and programs. Service providers saw the same need and suggested appropriate mental health services. These are just some information that each person shared. We won't read them all, but you just take a half a minute to look at one or two of the quotations. It gives you an idea as, especially we struggle to get the needs of our seniors met. It's very hard working and taking the bus. Okay, paradoxes. People are, live in a state of ambivalence. So grateful for what they have, regretting what is no longer in reach. And recommendations, which come from the community, focusing on a meeting place and intergenerational connections. Okay.
I just want folks to just look at our recommendations because it comes from the community, not us.
Then questions and comments really, but this is a concluding thought. Many agencies do not offer specific services tailored for older refugees. Benefits are open for anybody who can access, who meet the eligibility criteria. But does this mean that the specific needs of refugee older adults are not recognized and not served? So we would love your thoughts and input on this question. Is the big tent enough for everybody, or do they need to be specific pathways? Mm-hmm.
Thank you all very much.
Thank you.
My name is Anna or Nika Sucaldito.
My name is Htay.
And we're going to talk to you guys about our partnership between currently Wake Forest and the Karenni community of Winston-Salem, and particularly what we've been able to get done in the past year.
So the Karenni are from an ethnic group from Myanmar, also known as Burma. They became refugees due to the ethnic and still ongoing ethnic cleansing that happened. And so they resettled to the United States, and the first few families came in 2009.
And so for all of the projects that you guys see today, we did this within something called a community-based participatory research project, or CBPR. And what this really is a fancy way of saying that we all came together to work on this project. We had academic researchers come in, but importantly, we have community coming in. So it's not just people from universities telling community what is important for them. It's community saying, this is what we care about, this is what we're going to do. And then also bringing in other people who care about the community and support, whether that's MDA, whether that's the city of Winston-Salem, having those other connections. And so everything you hear about today, just for time, is going to be very short, and we hope to speak to them about them to you further at other times. But here's kind of our little lightning round.
And so we did a community health needs assessment, and we had some results and compared it to the states and the national. But I want you to pay attention to the 91%, because from the results showed that 91% had limited English proficiency.
We also talked to community members in their own Karenni languages about what they said the priorities were in their community. And so the things that they pinpointed as the major priorities were mental health, chronic pain, and healthcare access. And we use this needs assessment to inform all the other projects that you guys see and all the other ones going. So we're not just asking people and then not doing anything with that. We wanted to make sure it turned into action.
And we had our first peer review manuscript published, and it's now live as well. So whenever you guys want, we can email them out or share that with you guys.
And so we're very excited that people get to hear more about the Karenni and something that has Karenni feedback and Karenni writers on it. So something that we did next was focus on healthcare navigation, thinking about that priority of healthcare access that people talked about. And we were honored to be able to get a grant from NCAD, North Carolina Asian Americans Together, through their Asian Solidarity and Action Project, in order to be able to do this program. And so we were able to train 5 Karenni bilingual individuals who were already doing interpretation for community members, for family members, for people in need, and get them certified so that they're able to go in, have the training, and be accepted into, for example, medical spaces where this is really important, courtrooms, etc. And we also train them as health navigators. So not just the training, but also, providing emotional support. Transportation is a really big access issue, and so they're able to provide those services as well.
And then we did a follow-up with the 5 health navigators, and so the results showed that there were 134 community members that were utilizing the health navigator positions, but as well as other utilizations, so just not interpretations, but also driving them, helping them fill out papers and doing check-in and check-out and all of that.
Yeah, and this follow-up was just within the first 3 months. So this is something that we hope that is continuing, and people continue to be interpreting with these certifications and with this training. We also were able to collaborate with Dr. Morrison and Andrew on a grant that we received from the Bringing Southeast Asia Home initiative, the Henry Luce Foundation, Carolina Asia and Asian American Center. And it was this 2-part program where we wanted to make sure we brought things to the community, but also bring those providers in, get them trained, get them formally connected to the community so that it's something sustainable. So the first one is we created a lunch and learn for providers. We wanted it to be things that would bring in physicians, pediatric individuals, primary care, but also we had social workers from the schools. We had individuals from the city there, nonprofits, all different services, not just health-based, because that's what the community wanted. We were able to get 32 attendees. There was a lot of discussion about the recognition of language support, health education needs, and particularly how can we apply these findings into the services? How can we change the institutional processes so this isn't just one person having to push it forward, but it gets baked in? And so there were 4 areas of actions that the attendees focused on: connection of health services, educational systems, arts, and funding. There's not space to go through all of the different details that and plans that people put in place, but we've included some exemplars, such as different ways we can have connections to care that go across areas, and amending processes to recognize the Karenni culture and how that might affect, for example, student needs in terms of mental health and language.
And the second part, we had our health fair. So we had over 130 attendees, both adults and teens and children. We had 25 volunteers who acted as interpreters, who helped check in, handing out waters, and even as guards to direct attendings as they were coming in. We also had 71 patients who were able to receive health screenings at the health fair. And at the end of the health fair, we collected data using a survey, and out of 5, the average rate was 4.7 for participant satisfaction. And we had 88% who said that they learned something new, and then 64% who reported that they will likely use these services at the health fair in 6 months.
And so some ongoing projects that we're working about that we'd love to see some collaborations with and connections with, one of which is Vamedu, or My Big Brother. We were able to get grant funding for this program through the Asian Solidarity and Action Project. And this is a non-randomized clinical trial, particularly to improve mental health for Karenni emerging adults and Karenni children. Again, thinking back to those priorities talked about that people pinpointed in the needs assessment. We want it to be focused on mental health promotion, and also have it be culturally adapted. So we're able to work with the team at Soccer Without Borders, that is a national group that serves refugee and immigrant youth across the US, and they are working with us to adapt it to Karenni needs. And we're really excited about this because soccer is something that really brings the community together. And so it's a great gateway to start discussions of mental health in the youth, in the coaches, and also have it be in a place that's non-threatening and accessible for those who are not able to access kind of the medical institutions or healthcare institutions at this time.
And lastly, we have a big long-term project, which is called the LIAACRO Community Heritage Project. This project was funded from the Z. Smith Reynolds Foundation. And with this project, there are a series of workshops and programs to support the Karenni youth, such as helping them access to resources, giving them workshops. And so with this program, we are halfway through.
Yeah, and we're going to have the second half of programming later in the year that Lime, who is our artist, is also leading, who has a table out there if you guys want to see it. But that's some of our ongoing projects. And so that was a very quick overview, but we hope we're able to connect with you guys each on some of those aspects and kind of show some of the great work that's been done just within 1 year that the community is leading and is coming from priorities that the community is setting. Thank you.
Thank you.
Hello everyone, my name is Nathan Dang. For the past year, I've done most of my work in collecting secondary data on the Hmong community. Oh, and I also did it with Dr. Morrison, but I spent most of the past year collecting secondary data on the Hmong community in North Carolina in order to form a chronic health profile that will help inform the needs assessment that we're planning to do for North Carolina's Hmong community in partnership with the North Carolina Hmong Women Association. So I'll try to keep this short and concise, but I know with that there's going to be a lot of nuance that's going to be missing in the data that I present. So I strongly encourage all of you to ask any questions if you do have them. So to start off, major sources of data, we look through the US Census Bureau, which is an amazing source of data concerning the social determinants of health in communities. And so we looked at the US decennial census from 2020, as well as American Community Survey estimates, which are also the American Community Survey is conducted by the US Census Bureau as well. But we looked at estimates from 2021 and 2022. We also looked at CDC Places 2023 data, which is health data that's granulated, I guess, or I'm forgetting the word, but it's very precise, very specific to small communities. We also looked at Healthy Communities North Carolina 2030, County Community Health Assessments, and we also conducted literature reviews. So a critical note about our data sources is that even though the census does have Hmong specific data, the Hmong are misclassified as East Asian in the US Census when they should be classified as perhaps Southeast Asian or something that is more representative of the experiences that they have here, both living in Southeast Asia as well as here in the US. We also see that that the Hmong are often aggregated under Asian American, which means that there's a lack of specific information about the Hmong subgroup. So as you can see here, these are population counts for Asian Americans as well as Hmong specifically. We see that the Hmong are around 13,000 people here in North Carolina, which consists of a very small percentage of the state's population, but it's also just over half of UNCG's student body for comparison. So North Carolina is home to the fourth largest Hmong population in the US behind California, Minnesota, and Wisconsin. So it's quite a large population. And most of these Hmong are situated or located in this Hickory-Lenawee-Morganton statistical area. So all of our data is collected from this area specifically because this is a small area within North Carolina that is, I guess, economically, socially homogenous, if that's the right word. And it also is home to a majority of the North Carolina's Hmong population. So it is a good place to start. There's also outliers regarding Hmong living in other areas that we don't have to deal with when we look into this specific area. So we focused our health profile on the social determinants of health as a framework to build off of. So as you can see here, so when we first look at education access, we see that although much of North Carolina's Hmong population is highly educated, with 82% having attained a high school diploma or more, we also see that there is a significant disparity in those who are lacking a ninth grade education or less. Yeah, with 12% of Hmong having less than a ninth grade education here in North Carolina. In terms of economic stability, one thing to keep in mind is that these numbers that you're seeing, these figures, they are household incomes. They are not individual incomes. So as you can see here, they are relatively well off. They're making a good amount of money in terms of household income, because as you can see, in comparison to whites and blacks living in the same area, the Hmong unemployment rate is lower. They're also making around the same as the white counterparts. But as you can see in this next slide, we also see that the Hmong average household size is much larger than the white and black household size, with an average household size of 4.51 or 4 to 5 people, which is more mouths to feed, more people to financially support in the household. We also don't know the percentage of intergenerational households. However, based off of this average, we can tell that there definitely are a significant amount of intergenerational households or households with a lot of people living in them. We also see that in terms of computer access, that 100% of Hmong households have a computer, which is quite impressive when you consider the fact that compared to their black and white counterparts, they have higher computer access. However, because of this household size, we don't know for sure if all of these Hmong people have access to a computer in the house at all times. We also see that there is a significantly higher percentage of Hmong who have access to a broadband internet subscription in comparison to white and black people living in the same area. In terms of health access, we also see that the Hmong are significantly more insured when it comes to health compared to their white and black counterparts. So when it comes to Hmong adults, around 12.6% are uninsured, but when it comes to Hmong elders age 64 and up, we see that there is 100% coverage. And we do believe that this may be contribute that the fact that there are government programs such as I believe Medicare that help insure elders that are contributing to that number right there, but it is still impressive nonetheless. We also currently don't have any data on primary care visits because that type of data is very hard to access. So now we're going to be looking at county specific. We see when it comes to county health issues, so what we did is we looked through county community health needs assessments that for the counties that encompass the Hickory-Lenmar-Morganton statistical area to get a good idea of what exactly of the health needs are of the places that these people live. And so what we found is that all of these counties indicated that mental health was a priority health issue. In terms of what we found in the literature, we see that the Hmong are more susceptible in comparison to their other Asian counterparts and other white counterparts, etc., to a variety of chronic health issues, including diabetes, stroke, infection-related cancers, mental health problems like depression, COVID-related racism, as well as stress that comes from being in an intergenerational caregiver role. And so one thing that really stuck out to us as we were gathering the data was that oftentimes there was a missing Asian demographic, as in the Asians didn't appear at all in the data that we were looking at. This was taken from the 2023 Catawba Community Health Assessment. Catawba County is has the largest population of Hmong living in North Carolina, and what we saw was that Asians aren't represented at all in the county health assessment because they aren't represented in state data either. The community health assessment took from state data. We also see that there is an invisible Asian demographic here in Healthy North Carolina 2030. We see that there's data for all of these other groups, but there's no data. There seems to be no data available for AAPI, and we do know that these people do exist, right? They live in significant numbers here in North Carolina, but for some reason that data on AAPI is just not available. And so, what implications does this have for a community health needs assessment? Well, we know that the Hmong have a ton of needs, and so what we are doing is, for North Carolina's unique Hmong population, we're planning to conduct a community health needs assessment in order to figure out what exactly does this population need in our state, how can we best help them, and are there any needs of the Hmong population here in North Carolina that might differ from what they experience at a more national level, like for example in California, Wisconsin, Minnesota, because they live in more urban areas within these large states with larger Hmong populations, while here in North Carolina, the Hmong population is primarily more rural. And yeah, that's all.
All right. So happy to be here today. I'm Kat Bush.
I'm Betsy Renfrew.
And today what we're going to do is boil down 10 years worth of research, ethnobotany, oral history, and mental health into one well-being message from this community. So with a decade of collaboration, we actually want to start at the end. I want to highlight this is the work of John McGinley and our own Riswin Kassor up here. Woo! So in March of 2020, they did a survey of 26 Montagnards. It was youth predominantly because we were in the middle of the pandemic. And you'll notice here that 33% of these youth felt depressed, 33% felt anxious, about 17% had PTSD, and almost 13% had thoughts of suicidal ideation. This is higher than the general American population. Are we surprised? No, sadly we are not surprised. And what, rapid fire here, what might be some of the reasons for that? That the youth in the Montagnard population are not doing as well as the average Americans with mental health issues. One of the other things that we heard from the youth particularly is, am I Montagnard or am I American? And I hope that through these journeys together from our conversations today and the conversations that you're going to continue on with, is that the youth will understand that they are Montagnard and American. That you do not have to choose and you do not have to lose. You are amazing because you have the strengths of both. Because we saw these massive mental health issues, Ariel Pocock and Swim Sue, they worked on intergenerational conversations. So we had 10 pairs. We had an elder and we had a youth. And we did have an actual person to translate because we talked about some pretty deep stuff. We talked about the challenges that each generation had. We talked about the strengths of the community and their future. And they couldn't talk to each other about these things. So we did need to have somebody there. At the end of this interview process, 58% of the participants had decreased levels of sadness and worry. The other 42% felt the same. So we didn't make anyone feel worse, okay? 100% of the participants had positive emotions towards their interview partner. And this is an extremely low cost, high benefit way to improve wellness in the community.
I'm going to talk about two of the collaborative projects that I worked on with Kat. And I brought a script to help me slow down, and I teach ESOL, so this is what I've learned to do. One of the ones that we worked on was It was the medicinal and food plant use of Montagnard communities in Greensboro, North Carolina. And we believe it was the first of its kind. And this is something that, let's see, we interviewed 43 participants. And I should step aside and just say that both Kat and I had worked with, thank you, the Women's Learning Group, ESOL, that's what I've been involved in. Also Women's Weaving, I've done some documentation with that. And so it was an easy group to work with. I had already learned some Jirai. And so we had participants right there. 43 participated in this study. We've got little pie chart breakdowns and so forth here. And we went to their gardens and we gathered plants with their permission, of course. And we had some collaborative help here with our interpreters. We have one down at the bottom here, Hmong, and Hmong was especially helpful. We have the other two here, Swin and Swem also. We had 127 plant species. I have a different number here, but we had plant species that were vouchered and unvouchered, and Kat knows more about that than I do. But basically what we did was we took these plant samples and we dried them out and put them in a plant press, cataloged them, and then put them into all kinds of databases and so forth. My experience in this is that I know a lot about weeds that you can eat that you wouldn't want to touch. So I have a background of not science, but about what things are available to eat that wouldn't have known that. So what you see here is this is it. 3 people present, myself included. One of the things that I really enjoyed about this, and I thought was really meaningful, is this was truly a community collaborative project. We had an interpreter here who's also a collaborator, Swin in the background there, Kat over here, the woman whose garden we're in, and me taking the picture. And we had this 4-way dialogue going on about the plants, their uses, and the use of language to describe these things right here. And then the second study that I was involved in, which happened almost simultaneously, but 2017 to 2019, was oral history. And this one was wartime experiences in Vietnam before, during, and after the Vietnam War. So for this particular one, we interviewed 9 elders, although some of them were younger than me, but they're labeled elders. And these were people who were at least older children or adults at the time of the war and had good memories of these things. Both men and women were interviewed. They welcomed us into their homes. They told us stories of escaping Vietnam, fighting the communists in the jungle, or war atrocities that had previously been covered up. 2 of our interviewees told stories of recent ongoing persecutions, land grabbing, tortures, and murders of family members back home in Vietnam. Stress, talk about stress. I learned where the stress comes from with this. Last thing here, we had a couple here were so intently passionate about passing on this information about how they lived in the jungle before they were discovered and came to the United States, is they made a little video with us about how they survived, and they really just wish that this gets passed on so that everyone knows what they had to do. And they really are resilient. They really have been true survivors here. We can't play this at this time, but I think we'll have ways of accessing this in the future. And I think that's it.
So we just talked about mental health, we talked about ethnobotany, we talked about oral history. Are these connected? Why or why not? Beautiful, thank you. That's I couldn't have said it better myself. That's awesome. So we did not mean for these to be connected. We just kind of went on our way for 10 years. This is a research paper, which I love the title. Who are you from? The importance of family stories. These are called intergenerational narratives. And I believe that intergenerational narratives can help us trump the other intergenerational thing, which is what? Trauma. Finally, we have an intergenerational that we want to cling to. This is intergenerational narratives. This is who you are from, and this is where you are from. It connects you to self through time and in relation to your people. It leads to the intergenerational self. It helps you understand and deal with life's experiences and challenges, and it appears to contribute to resilience at all life stages. It is health promoting, and it is not only good for children, but their parents and their parents' parents. And so what we have done accidentally, I think, is that we have given space for 10 years for people to tell their stories. Some of these stories were indeed unbelievably heartbreaking. But some of these stories are full of joy and love. For the youth, this is your future. These are your stories. This is who you are from. This is where you are from. And when times get tough, you can depend on these stories for strength and resilience. These stories are the gifts that the elders and the youth gave each other. This has culminated in the Montagnard Cultural Archive. This is a very big thing for 3 folders. There are 3 folders, and they contain every picture, every interview, every transcript, every audio file of tribal languages, every video. They are yours. These folders has been given to LIAACRO. They are for the community. They are your stories. And you all will decide what you want to do with them. They have all been anonymized because of the persecution that Montagnards still face in Vietnam. And I was too scared to let the names go. They have all been stripped of names. In one of the interviews, Ariel Pocock actually was this horrendous story. And she said, "Thank you for sharing." And the elder said, "Thank you for asking." They want to tell their stories. And the thesis of all of this, after 10 years, we did not see this coming, I don't think, is that intergenerational narratives give a sense of self, community, belonging, identity, and strength. And this, I believe, is going to increase overall well-being and help heal intergenerational trauma.
And our thanks to the community researchers, Vung.
Where's Vung? Swim was here. Yeah, thank them.
We couldn't have done it without them. I really, really appreciated their assistance.
This talk is given in memory of Hmong Bot. He contributed greatly to the archives. He had immense ethnobotanical knowledge. He is greatly missed, but his stories and his knowledge and his voice live on in the Montagnard Cultural Archives. Thank you.
What I gather from what was discussed is that in order to help someone, in order to help people, you need to know what the needs are. In order to know what the needs are, that means you need to talk to the community and find out what those needs are. What they have shown is that there's a lot of data that's missed. So you can't help anyone if you don't have any data to derive from. We have to involve the community. Institutions are very important. Not only institutions, but trusted institutions is what we need to partner with. We know that there's a lack of outreach into the communities, and a lot of healthcare systems expect people to come to them, and we need to go to the community. Not only that, but we need to involve the community in whatever we're doing. Language is a huge barrier. In order to help the community, especially when we have different sectors of the population, like you said, Asian American is a huge group, but within that group, there's a lot of different separate organizations and people that they have different needs. So we need to know the differences. We talked about navigators, which I really love the fact that we amplified that, because you want to have people from the community to help their community. That person in the community is trusted. And so they're going to be able to make the connections with the community and translate that information. The other thing that I would say is we did have some data, but it was misrepresentation of the data. So we don't want to build programs based on data that's not good. One thing that I learned very on in my career is when it comes to data, junk in is junk out. So we make sure that we're having to collect the accurate data, but we have to make sure we're doing it with the community. We collect the data, then we need to go to the community and say, tell me what this means. Is this accurate? Is this what you see? So we need to validate that data. And I would say the last thing is the thread is that mental health is a huge issue. And we need to make sure that we develop in programs to help with the mental health throughout the generation. We talked about the intergenerational trauma. So we need to make sure that we have mental health services in order to help people. And one thing that I say is, we talk about access to care. Access to care is getting access to the things you need when you need it. If you cannot get to things when you need it, it's not really access. And just having health insurance is not access. There's a lot of people who have health insurance, but they don't know how to use it. And so we know that we have to understand we have people that come from different countries, different cultures. We need to learn their culture, but preventive health is not necessarily in someone's culture. So we have to make sure that we understand what health means to them, help them to navigate our healthcare system. I've been in the healthcare system for years, even I get confused. So just imagine coming from another country. For those who have never been to another country, it's very different. I have to go to another country. I spent 25 years in the military. I've had to go to different countries and try to learn the language, try to understand. And so people can't really appreciate that unless you have that experience. And so you think about, refugees, they're coming here from trauma to another place that's necessarily trauma, but it's really traumatizing to come to a different culture. So that's what I gather from that, what we've had so far. To you.
I know we're cutting short on time, but I just wanted to highlight a couple of threads that I heard through these presentations that we see anecdotally out in the field every day. And I want to thank you guys for presenting this because this really does get data to what we see. And the first thing is that so many programs and systems are one size fits all. And your access is basically how well do you conform to what the program that is meant for, rather than actually seeing the person in that. And so it really does ignore age differences. It treats all refugees as one category, regardless of age, regardless of nationality, ethnicity, or a certain circumstance. And so we began today talking about how healthcare disparities are really about, is there a service available? Is there access to those services, and is there knowledge of how to access those services? And what a lot of this data shows us is we also need to flip that on its head, because that puts a lot of burden on the community itself. So what are we asking of the systems? So do the systems themselves know what's provided? A lot of times we see with healthcare professionals that they don't know what resources are available. Are they aware of differences in populations? Do they know what care is actually available depending on different immigration statuses when they're providing care? And so as much as there is an impetus to have community help community and build those pathways, we also need to make sure that we're educating the systems themselves so that they do provide those pathways in the midst of it. And the other thing that really connected to all of these was you do see mental health. And mental health is really connected to lots of feelings of loneliness and isolation, especially in the communities that we see. And all of those barriers to health, they counteract with each other. You see the housing crisis now, where we heard while housing wasn't great at Summit Home when the Montagnards first came, there was community there. Because of the housing market now, and because we're seeing more and more non-local landlords, there's not that connection, and so new arriving populations are more spread out. They're not as localized, which increases feelings of loneliness and isolation. The same with transportation, and so all of those things are interactive. And in the midst of this, we could kind of boil it down to one thing: is within our systems, within our communities. The biggest thing for mental health is for people to be seen and for people to be heard. And in the midst of that, if we strive toward better understanding of demographics, it helps people feel seen. As we strive to provide services that help with connection, that people could be seen, that's going to go a long way. So those are kind of the ties that I saw between all of these.
Gentlemen, thank you so much for your very succinct statement. Thank you very much.